Hi, class. This is now the last part of transfusion medicine, and we are going to discuss on transfusion guidelines and transfusion reaction. Upon the release of the blood unit, it is the task and responsibility of the nurse in charge, as well as that of the medical technologist, to check all parameters to prevent clerical errors from happening. So they have to double check the result, the name of the patient, the serial number, the expiration date, the blood group, and the component that would be given. And the blood unit that would be released should be transfused within 30 minutes from release. Otherwise, it has to be returned or given back to the blood station for safekeeping. Upon the release of the blood unit, the temperature should be maintained at less than 10 degrees Celsius. Okay, if not, bacterial contamination may occur, as well as the ATP and glucose may decrease. The infusing solution that we use would be the normal saline solution or the 0.9% sodium chloride. This is used to decrease the viscosity and improve the flow rate during transfusion. Some solutions are not intended for use during blood transfusion, like the D5 water, which is a hypotonic solution. It can cause aggregation of red cells and cause hemolysis. Lactated Ringer's solution, which would contain ionized calcium, is not also used as it promotes clot formation. Drugs or medications should not be added during the transfusion of blood as it can cause pH-induced hemolysis. Filter sets would be used to remove the fibrin clot, which are formed after 5 days of storage. There's a standard filter set that can be used for RBC components or for fresh frozen plasma or cryoprecipitate. For platelet concentrates, they would use a special platelet filter set. Upon inspection of the blood that has been released, so as much as possible, you have to go to the ward and inspect the blood units that would be given or that would be taken from the blood station. You have to check on the appearance of the blood component. Usually, what we would look for would be any sign of changes in the appearance of the plasma. So, in this case, the plasma is colored yellow. It should not be green, blue, or red like this one, which would mean that this is hemolyzed. A blue or green may mean there's a contamination. In those cases, you have to tell the nurse in charge to inform the blood station that you have to replace the blood unit. For venous access, for adults, we prefer the anticubital fossa, and we use a large bore needle, which is gauge 18. If we are going to use a gauge 21 or gauge 23, it may induce hemolysis, and we have to extend the infusion time. For infants and neonates, we are not going to use anticubital fossa. We are going to use the umbilical vein or the scalp or the foot veins. For warming of the blood warmers are not routinely used. You only see them in areas that uh, would require rapid transfusion or large volume or exchange transfusion. So it means it's placed in the operating room theater. It is placed in the ICU. Okay. So when you say large volume or rapid transfusion, it means that the rate of transfusion would be in excess of 100 ml per minute. And for children or infants or neonates with exchange transfusion, it would be transfusion of blood for more than 15 ml per kilogram per hour. So the blood warmers would be used to elevate the temperature from 10 degrees to 37 degrees. And we use dry heat with warming plates or water bath as blood warmers. So this is an example of a blood warmer. This is an example of a dry heat with warming plate wherein you place a tubing on the recessed portion of the warming plate, and this will be used to warm single blood units. There's also a larger uh, warming blood warmer that can warm 2 to 4 blood units. Aside from that, blood warmers can also be used if patients have cold agglutinins. Okay, so for component infusion, we have to take note of the speed of infusion. So we start with the slow infusion, that is 2 ml per minute uh, for the first 15 minutes in order to check for any transfusion reactions like anaphylactic shock or anaphylactic reaction. RBC containing products would then be infused at a rate of 60 drops per minute or 240 ml per hour. For platelet or platelet concentrate or plasma derivatives, it is given fast drip within 30 to 60 minutes. So the maximum infusion time would be 4 hours. So it should be finished within 4 hours in order to prevent bacterial contamination. In special cases wherein patients are known to have congestive heart failure, we have to reduce the amount of blood to be given per hour. So these are important or very important transfusion guidelines that I'm going to share to you, and these are uh, all taken from Henry's. Okay, so this is the red cell transfusion guideline. Okay, the main reason would be the presence of anemia, the acute blood loss of more than 15% of estimated blood volume. In the operating table, it is the patient presents with a hemoglobin of less than 9 grams per deciliter, and there's an expected blood loss of more than 500 ml. In a critically ill patient, like in the ICU, the hemoglobin, once it goes down to less than 7, it is an indication for RBC transfusion. In patients with acute coronary syndrome, those with myocardial infarction, with hemoglobin of less than 8, that would also be an indication for RBC transfusion. Hemoglobin of less than 10 with uremic or thrombocytopenic bleeding, and for sickle cell disease. For platelet transfusion, these are the guidelines. We have the thrombocytopenia of in stable patients. The thrombocytopenia would be less than 10,000. So per UL, this is an indication for platelet transfusion. If there's an invasive procedure with low risk of bleeding, but the platelet count is less than 20,000 per UL. If there's an invasive procedure with high risk for bleeding, so we elevate. Okay, so if the patient has a platelet count of less than 50,000, but is bleeding with high risk for bleeding, that is a candidate for platelet transfusion. And then we have central nervous system bleeding or retinal bleeding, even with a platelet count of less than 100,000 per UL, then that is a candidate for platelet transfusion. Or microvascular bleeding due to platelet dysfunction. And then we have the plasma transfusion guidelines. So most common would be a coagulation factor deficiency, and then we have the dilutional coagulopathy seen with cirrhosis and hemorrhage and liver disease, disseminated intravascular coagulation. We have the Coumadin reversal, TTP, and acute trauma resuscitation. For cryoprecipitate, we have the factor 8, deficiency, factor concentrate, unavailability, and then we have the von Willebrand disease, hypofibrinogenemia, factor 13 deficiency, uremic bleeding, and we have the topical fibrin sealant. Okay, and then we have the guidelines for neonatal transfusion. Okay, so these are for RBC, for plasma, and platelet, which would be different from those in adults and children. So now let's go to the transfusion reactions. In a clinical setting, like in the hospital, usually we get around 1 to 3 transfusion reactions uh, in 400 transfusions. Okay, and that would be in a quarter. Okay, and the transfusion reactions would be divided into two categories. We have the non-hemolytic and we have the hemolytic transfusion reactions. Of course, the non-hemolytic transfusion reactions are the ones that we commonly would encounter in the hospital setting. So first, we have the febrile non-hemolytic transfusion reaction, which is one of the more common reactions, and this is identified with a temperature rise of more than 1 degree Celsius during or after transfusion with or without chills. So take note that there's a temperature rise of more than 1 degree Celsius, but you include in the criteria that the temperature rise should fall within the febrile temperature setting. So it doesn't mean when your patient is 35 degrees Celsius or 36 degrees Celsius and elevates to 37.1, then that is considered as a transfusion reaction. So no. So take note that you only arrive at this conclusion if the temperature rose to febrile setting. Okay, so this is seen in 1 to 3% of RBC transfusions. It can be seen if the platelet transfused is 5 days old, and it accounts for 43 to 75% of all transfusion reactions. Mechanism for febrile non-hemolytic transfusion reaction would be the accumulation of pyrogenic cytokines, and these cytokines would be coming from leukocytes. And the treatment that we perform would be to give antipyretics, and we discontinue the transfusion. In a study by Kelly et al. In 2000, we can prevent febrile non-hemolytic transfusion reaction in platelet concentrate transfusion if we give less than 5 days old. And we can also do preventive measure by doing a pre-storage leukocyte reduction. Pre-storage leukocyte reduction. So through filters. Next transfusion reaction, which is also common, would be the allergic reaction, which is mediated by IgE. Patients would complain of rashes, itchiness, erythema, cutaneous flushing, and 10% of these cases would exhibit difficulty of breathing. So the specific antigen for reaction is not yet identified, and IgA and haptoglobin deficiency has been seen to have allergic reactions in rare cases. So the treatment for allergic reaction would be to give diphenhydramine 50 to 100 milligrams. And if the allergic reaction is severe, like having difficulty of breathing, we give epinephrine and we discontinue transfusion. So if you happen to have a patient who had a history of allergic transfusion reaction, so the next time around you can give antihistamine and wash red blood cell. Next, we have the anaphylactic reaction. So for anaphylactic reaction, this refers to a reaction seen with those with immunodeficiency. It means that they are IgA deficient patients and they have antibodies developed against IgA. So all all donors would possess the IgA, and this would be a reaction that would seen immediately after infusion of less than 10 ml of blood product. It can also occur in patients with haptoglobin deficiency. So because it's an anaphylactic type of reaction, so you have signs and symptoms of shock like respiratory distress, hypotension, you have nausea, vomiting, diarrhea, and then we also have fevers and chills. So the treatment that we have here would be to give epinephrine, to give steroids, wash red blood cells, and um, the best type of treatment would be to give IgA deficient blood, but that is very difficult to look for. Next, we have the bacterial contamination, which there are gram negative and gram positive organisms that can cause such transfusion reactions. The gram negative rods would be the Acinetobacter, E. coli, Klebsiella, Salmonella, and Serratia, and they are known to have greater risk factor as they can produce endotoxin. We have the gram positive, which would be the Staphylococcus and Streptococcus. And the best way in order to check for bacterial contamination is to perform blood culture. Okay, so what are the risk factors? We have the gram negative rats, greater age of the patient, elderly, smaller volume because they would have more uh, bacteria, and then yeah, younger age of stored platelet concentrate. The signs and symptoms would be similar to that of shock, like facial flushing. We have the fever, GI symptoms, and shock. And for treatment, we give antibiotics, we give steroids, and preferably we have to. So the blood bank has to make a culture of pre-pooled blood. So he has to get, or the one in charge of the collection should get pre-pooled blood culture so that you know if one of them has uh, growth, bacterial growth. But this is uh, not not very reliable because there might still be low number of bacteria that can produce colonies. So preventive measures for bacterial contamination would be to perform aseptic technique during blood donation. Infusion time should be followed, and we should uh, perform careful component thawing for the blood station. And as doctors, because we are going to act as blood bank physicians in the hospital, we look into the donor interview, okay, and check on any signs of manipulative procedures like even oral prophylaxis, uh, like colonoscopy. So these are procedures that can induce bacteremia. And lastly, we have to check the bag for any signs of bacterial contamination like bubbling, hemolysis, or clot formation. So this is an example of a blood clot, or this is a fibrin clot, which this is normal, and this can be seen during storage. This can be removed by the filter set. However, if there's a lot of blood clots in the bag, then that's worrisome already. Another sign of bacterial contamination would be the presence of bubbles. So those are telltale signs of bacterial contamination. Next, we go to circulatory overload. And this is a type of transfusion reaction which is associated with congestive heart failure. Signs and symptoms is signs of congestion and edema like dyspnea, hypertension, tachycardia, and cough. So, in persons who have history of congestive heart failure, we need to perform alicoating uh, and give the blood in smaller volumes at different time intervals. Aside from that, we can give diuretics, oxygen for these patients. Okay. Next, we have the TRALI or transfusion related acute lung injury. And this is related to circulatory overload because both of them would present with pulmonary edema. But this one would not present, okay, with history of congestive heart failure. So it presents with non-cardiogenic pulmonary edema. Uh, there on X-ray, both would be the same. Okay, for circulatory overload and TRALI, both would be the same. There would be the presence of bilateral pulmonary edema, but in this case, there's absence of heart failure. Patients would be in respiratory distress, and the mechanism here is the presence of antibodies to granulocytes or to the human leukocyte antigen, as well as the presence of complement activation. This confers 20% mortality, and it should be resolved within 48 to 96 hours from the onset. So we treat them with steroids, or and in cases wherein they really have difficulty of breathing, we can do intubation. Next would be iron overload, which can be a transfusion reaction for those who are chronic recipients of red blood cells. So per unit of the pack RBC or the whole blood, it contains 200 milligrams of iron, and this would become significant if a patient or a person would be transfused with 100 pack RBCs or more. So this is a sign of hemosiderosis. It affects the liver, the heart, and the pancreas. And our treatment for this would be an iron chelating agent called deferoxamine. Next, we have another transfusion reaction, which is the post-transfusion purpura. And this happens, for example, you have a patient whom you had a transfusion, and after 1 to 2 weeks, patient would complain of having petechial rashes, and then has thrombocytopenia, then think of a post-transfusion purpura. And this is attributed to antibodies to platelet-specific antigen. And what we have to do is we perform therapeutic plasmapheresis. Okay, so it's the patient who is going to undergo plasmapheresis. Next, we have the transfusion-associated graft versus host disease, or TGVHD. This is seen in immunocompromised patients. So it means that we are going to transfuse allogenic T lymphocytes to our patients who are immunocompromised, and the T lymphocytes would think that they are the host lymphocytes, would engraft to the lymphoid tissues and would then induce a cellular or humoral immune response. It means that it's going to kill all of the cells that are foreign. It occurs within 2 to 50 days after transfusion, and um, more than 90% of those with TGVHD can be fatal. So manifestations of liver dysfunction, diarrhea, rashes, as well as pancytopenia would be noted. Preventive measures: if you have a patient who's immunocompromised with comorbid factors, okay, in order to prevent TGVHD, we irradiate the blood units. Okay, take note of the expiration date, and another is to use leuko-reduced products. Okay, and they have also noted that those with blood consanguinity would have increased risk for TGVHD if you're going to donate blood for relatives or for families, for siblings. Next, we have the hypotensive reaction, which would mean that during the course of the transfusion and then you are monitoring the patient's vital signs. So there's a drop of at least 10 millimeters mercury systolic or diastolic pressure. So you have to uh, take note of this one. It's associated with bradykinin release, and transfusion should be discontinued and patient should be placed in a Trendelenburg position. So again, for hypotensive reaction, you take note of the usual blood pressure or the baseline blood pressure of our patients prior to the start of transfusion. So now we go to the other category for transfusion reaction, which is the hemolytic type of transfusion reaction. So there are two. We have the acute and we have the delayed type. So for acute hemolytic transfusion reaction, we have here the rapid destruction of blood cells within 24 hours. And this is common in whole blood and PAC-RBC. And usually, the one that we most commonly encounter would be ABO incompatibility due to clerical error. Okay? And for alloantibodies that can cause acute hemolytic transfusion reaction would be uh, anti-kel, KID, and Duffy systems. So what happens with acute hemolytic transfusion reaction is there would be signs of shock, okay, with DIC, with vasoconstriction, renal ischemia. So patients would suffer with acute renal failure, hypotension, and patients would also complain of chest pain. Generalized bleeding would be the uh, differentiating feature from the other shock reactions of non-hemolytic type. So once you see generalized bleeding, like if you would see it coming from the nose, there's petechial rashes, there's the presence of blood coming out of the urine output, then you think of acute hemolytic transfusion reaction. Okay. Uh, what would be the treatment? Intravenous fluid, diuretics, and platelet transfusion. Okay, so that's why it's very important that physician residents should be part of the monitoring of patients who are undergoing blood transfusion. So next we go to the delayed type of hemolytic transfusion reaction. And this is not recognized until 3 to 10 days after. So it means that the patient may have been discharged. Okay. So, and this is due to history of previous transfusion or pregnancy. And there's a low titer of reactivity. It means that we do not see frank bleeding, but we would see a decrease in the hemoglobin and hematocrit. So patients would manifest with anemia, there's fever, and there is jaundice. So those are features that would mean that there's a delayed type of hemolytic transfusion reaction. So what is your responsibility? So as doctors, it is your responsibility to follow up the monitoring, the vital signs. Okay, you are going to be the one responsible for the transfusion form, okay, to make sure that it is complete. So in the event that there's a transfusion reaction, you should be present and should be the one who will perform the treatment guidelines. So always check the label, okay, for expiration date, the blood group, the RH factor, the unit number, component. Okay, so and then if it's irradiated, if it's a wash red blood cell, so you already know what would be the lifespan. You always check for the integrity of the unit. So if there are evidences of leaks, and check for abnormalities of the color, okay, or too much of clots, or cloudiness, okay, or hemolysis. So I hope that you learn a lot. Okay, this particular lecture is very important to you. So thank you and have a nice day.